Hello, I want to welcome everyone today. I'm Wendy Mindel, an advisory board member of the Mount Sinai Institute for Exposomic Research, and it's great to be here with all of you today. One of the most exciting frontiers in environmental health research is the study of exposomics. It involves understanding how exposures across the entire lifespan, from before birth through the end of life, shape long-term health outcomes. The quality of the air we breathe, our stress levels, the chemicals in the products we use, and what's in the food we eat are measured and studied for their biological effects, with the goal of translating that knowledge into smarter public policy and better health outcomes. Today, we'll hear about a groundbreaking program at Mount Sinai, the first of its kind in the country, that integrates exposomics specifically into women's health in order to improve our understanding of how environmental, social, nutritional, and chemical exposures affect women. Please use the Q&A function to submit your questions. We'll try to address as many of them as possible during the session. And if we can't get to them all, we'll follow up when we share the recording. It's now my pleasure to introduce our speaker, Dr. Rosalind Wright. Dr. Wright is Dean for Public Health and co-director of the Institute for Exposomic Research at the Icahn School of Medicine at Mount Sinai. A renowned physician scientist, Dr. Wright's research focuses on how protective factors in our social, biological, and built environments can positively influence health trajectories. I'm delighted to now turn it over to Dr. Wright.
Thank you very much, Wendy. Can you hear me okay?
Yes.
Great. Well, it's great to be with everybody this afternoon. Great to be here to talk about what I think is a really critical emphasis on women's health in whatever context, but also in particular in relationship to environmental factors that contribute and all the way up to exposomics. So I'm going to try to talk to you today about why we made that shift, why we think it's important, and what we think the gaps are that we uniquely can help foster the next generation of researchers, clinicians, etc., to incorporate environmental exposures into women's health programming. So I'm going to go ahead and start to share my screen. And hopefully everyone can see that.
It's good.
And it's the full view.
Yes.
Okay, so we've started, what we're going to really talk about is a new program we've initiated. We've been funded through the National Institutes of Health, through the Building Interdisciplinary Careers in Women's Health program called BIRCH. BIRCH has been around at the NIH for about 25 years. They just celebrated their, I guess it's silver anniversary, right? We were down at NIH to do that as new members in this club. Mount Sinai has not had one of these in the past, but we thought it was time and we thought it was good to focus it specifically around exposomics. And we call it Life Course Exposomics and Analytic Program, or LEAP in Women's Health. We're very proud of that because we really do think this is going to really advance our understanding of what drives health trajectories, particularly for women. But you have to study, you'll see, we'll talk about why we have to study men right alongside and why it's important to do both. And I think what we're going to talk about is missing windows of opportunity or missing understanding of critical life periods when we think about how environment can impact health over the lifespan, over different portions of our lifespan, etc. So let's see if I can get the slide to advance. There we go. So just some overarching things that have always really stuck in my head, and what, for people who know me, my research has, even though I'm an adult trained physician, my research has really been interested in going back and finding the root causes and taking me all the way back to pregnancy, another critical window. But there are a lot of things that just remain unexplained for women's health trajectory and their longevity over the lifespan. And there's, we all understand they're very unique experiences and exposures across a woman's life as compared to men, boys and men. So women live longer than men, but they have much more illnesses and disability across their lifespan. So they're more impacted by many, many chronic disorders. There's a site there if you're interested in going a little deeper in that, which has been described recently. We've known this for a long time, but it keeps coming back to us. It keeps coming back in the literature. We still don't understand it. And women experience, for example, both higher rates of mental health issues as well as physical health issues and behavioral health issues. So, for example, women experience higher rates of internalizing disorders, and by that we mean anxiety and depression, than men. Pretty much from early days in our lifespan, and we'll touch on that, as well as post-traumatic stress disorder. Even though both men and women are exposed to things that might induce those kinds of things. And then if you look at cardiovascular disease risk across the lifespan, it's very interesting for women because we have lower risk when you compare us to men earlier in our life stage, but postmenopausal women have higher rates, just as men, for later life cardiovascular disorders. Compare them to premenopausal women. So there's something that changes during another life period that's very critical to women, that menopausal transition period. And then we know things like, drugs that we may encounter over our life course, which may be unique to women, like hormone replacement therapy for menopausal symptoms, have been associated with both increased and decreased risks of both cardiovascular disease, other chronic diseases, respiratory disease risk. And the question is, why mixed? And I'm a pulmonologist, so I added in respiratory disease risk because I think the most important organ in the chest, maybe not always the heart, the lungs are there as well. And women respond differently to men than men to many treatments and drugs over our life course too, and really has not been studied, examined, and understood. And we also know that men and women, males and females, differ in many biological and social factors that fluctuate and sometimes accumulate over our lifespan. And if we can understand better and describe that exposome, that sort of the health relevant environmental factors, whether they're social factors, as Wendy alluded to before, chemical factors, lifestyle factors, etc., and understand the cumulative effects of that over the life course, we're going to really shed light on why health trajectories are different for men and women. Why do they diverge? Why some women are more impacted than others? It really is going to depend on that mix of these exposures. So one thing we've done very well at our departments and institutes here at Mount Sinai, as we've all been very interested in environmental health and in the larger scope, not just one chemical or one exposure at a time, but multiple exposures, more of this exposomics types of pictures as comprehensively as possible. Let's measure as much as possible during what we think are the critical periods of development, where we can have impact if we can understand, what's driving health at that time period for particular people, for particular groups of people, get a little bit more precise in how we want to understand how it affects health, and maybe, not maybe, but needs to ultimately inform interventions and prevention strategies to improve those outcomes. So we've done very well thinking of the very early part of life, beginning in pregnancy when the baby's developing, and that you see green and blue on this slide because when I have in the box here the blue, what we're really interested in is in understanding environmental exposures from that very early part of development, the baby developing in mom's womb. So what's mom being exposed to during pregnancy that gets to the baby and starts to program that child's health, all in the blue. And we follow them over their early life period, and we look at environmental factors and try to look at harm-inducing environmental toxicants, as well as thinking about those that do harm reduction, things like nutrition, good nutrition, caregiving environments, these kinds of things, which we've talked about in some of our other presentations that we do. So again, we've done very well there, but when you think about we want to really better understand women's health, you have to then look specifically within those particular groups that you're interested in. So we look at sex-specific effects, and I can't remember the last study we've done where we didn't always look at, is it different in boys and girls, no matter what life period you're looking at for those children in the studies that we do. And I'll just give you some examples. I mentioned that women have higher rates of certain mental health disorders over the life course, particularly internalizing problems, things like depression, being predisposed to developing clinical depression and anxiety as you get older. So while we want to understand it very early on, so perhaps we can intervene earlier. So we've done, this is a study that one of our trainees has recently completed in the National ECHO Consortium, the Environmental Influences on Child Health Outcomes. That's a study we're a part of, but it's a national consortium across the United States. And you're able to pool mothers and children from that data set and look at different exposures on these types of outcomes. So we looked at it in about 2,000 mother-child pairs across a number of studies in the ECHO Consortium. And we looked at, here we were looking at metal mixtures, so multiple metals. Here we looked at 4 specific metals, which we know are toxic to the brain. There's lots of data to suggest things like arsenic, cadmium, manganese, and lead are toxic to the brain. Probably most people are most familiar with lead and lower IQ in kids. That was discovered quite some time ago from folks both here at Sinai as well as elsewhere. And then we looked at kids when they were between the ages of 1.5 to 5, so preschool aged kids, and we looked at the most widely used measure of these kinds of behaviors and symptoms that might reflect later risk of actual depression, anxiety in these kids. And then we looked at it by boys and girls to look at sex-specific effects. Well, we already know there's lots of evidence that girls are more predisposed to going on to have these problems as they get older. And these data would corroborate that. So the kids who were, the moms who were more highly exposing the developing fetus to higher levels of this mixture of metals during in utero development, the girls were much more likely to develop increased problems, increased internalizing problems in particular, and even reach a cutoff where we become concerned they're at risk of developing clinical depression. Boys are at risk to some extent. You can see that in the lower right-hand corner, but not as much as the girls. It really is the girls. And we've shown this over and over and over again. We've also looked at maternal smoking during pregnancy, predicting child blood pressure and risk for hypertension in early school-aged kids. And you don't have to get into the graphics, but if you're on the right-hand side of that dotted line in each of these subsets where you look at SBP, systolic blood pressure, diastolic blood pressures, DBP, and then risk for hypertension in these kids as we followed them. This again is in the ECHO cohort. In systolic and diastolic pressure, if your blood pressure is 160 over 70, the top one is the systolic, the bottom one's diastolic. We always follow those like that, and you've heard that from your docs. You can see that if mom smokes during pregnancy, these kids are much more likely to develop elevated blood pressure as well as meeting criteria for hypertension early on. So we know this, and we looked at it in boys and girls. We didn't see a whole lot of difference in boys and girls in this one, but you can also look at how the kids are biologically responding in relationship to the toxicant exposures they might experience early on in pregnancy in the mom. So we've looked at here air pollution. PM2.5 is fine particulate air pollution. It's what we breathe every day from the cars and trucks and things that are ongoing out in our environments. And if for the moms who had higher level exposure to PM2.5, and that can be based on where you live and how likely you're going to be exposed to those and how much of that is in the air. And we looked at it, and when these kids were 6 months, at their cardiac response, their heart response to a stress challenge that we did, and that's, just a particular thing called the still face paradigm on the bottom there. And you can see that the flattened gray area, those are the kids of the moms who had higher level exposure to PM, and they had very atypical patterns. What you should have is a nice, curve like in the blue. So that just says we're already programming the kids' physiologic systems that might predispose them to both things like hypertension, like cardiovascular disease, but also it can have an effect on behavior and neurodevelopment and their likelihood of going on to develop things like anxiety, etc. It all connects together ultimately. And boys and girls, it seemed that boys were more affected there. And here we looked at stress levels in the moms prenatally, and we measured that with a biomarker, cortisol levels that we got from collecting hair in moms at the time of delivery. And you can go back in time and know and understand how much cortisol they were producing as a marker of their stress, their own stress response while that baby's developing. And the kids with higher level exposure to cortisol, more stress in utero, they had a very atypical heart rate response to a stress challenge when they were 6 months old as well. And you can see the dark blue curve is the one I want you to look at. So in boys, everybody has this nice W shape. That's what we would say is typical response to the type of challenge that we're putting these kids through. And the girls aren't, particularly for the girls born to women who had higher level cortisol. In the dark blue, you can see you lose that whole W shape, right? They're very flat in response to that. That's not good because that particular pattern has been linked to neurobehavioral problems, things like anxiety, but also greater cardiovascular risk as they get older. So it's very important to start early and understand this for development of children's health. But why we look at boys and girls is because if you're going to understand the different trajectory of health across a lifespan, you really have to understand that girls and boys develop very differently. They're physiologically different from the time of conception. The placenta that develops with them in utero, very different from, whether you're carrying a boy or a girl, and the types of signals it's putting out, etc. And they may be very differently responsive to the types of environmental factors that we're looking at in utero exposure as well. Why is this important? Because if we can understand these kinds of things and the differences between boys and girls when we're taking care of pregnant women, we may actually monitor them differently if we know that they're carrying a girl, and we have kind of data like this that suggests, well, you also have this environmental picture that we're going to start to characterize more in the clinical setting. And now we need to do something different as we manage that pregnancy. You're at higher risk of X, Y, and Z. We've always monitored higher risk pregnancies in different ways, and this is kind of a way to think about how we might translate some of this work to clinical practice, if you want to think of it that way. Well, let's change our focus, right, of this picture, because what we've been interested in the past is that mom during pregnancy as she's a conduit of the environmental exposures and the physiologic programming that starts in utero that puts these kids on a different health trajectory for various outcomes, as we've looked at and focused more on mental health and cardiovascular disease as examples, but we could talk about almost anything that you want to talk about with respect to developmental outcomes and health. So now the red box is around, let's focus on the mom. That pregnancy is a missed window of opportunity that we have not as well. Not that we didn't think it was important, but we had a lot to do to sort of start to think about how it's programming the baby. But I can tell you that we're not the only ones that are now thinking about, if we're really going to advance women's health and the understanding of some of these gaps in our, that we pointed out in the first slide, we need to think about pregnancy as a critical window for the mother that might then differentially program her own health as she is in the postnatal period, goes through subsequent pregnancies, and as she reaches older adulthood, perimenopause, menopause, etc. And why is risk different? Is going to be different there. This is kind of a simple way to think about it. I'm just looking at lifespan on the bottom axis there, and on the vertical axis looking at vascular risk or cardiovascular risk across the lifespan. And you think about that black line is the threshold for clinical detection. When a woman presents with clinical manifestations of cardiovascular disease and it gets picked up. But when does her risk start? The pregnancies that she's having are turned out to be very important. And we hadn't really been connecting the two so much. So here I'm going to use an example of a normotensive, healthy pregnancy versus a pregnancy where a woman develops hypertensive disorders of pregnancy, didn't have hypertension before, started having problems with hypertension during the pregnancy. It may or may not go away after the pregnancy, but here we're just talking about within that period. And she could develop a serious complication of pregnancy, hypertensive disorder of pregnancy called preeclampsia, which is really a serious condition for both mom and the baby. So here's kind of normal healthy pregnancies. If you look on the left-hand side, that's early life. When the little blips come up, those are the pregnancies that I'm talking about. So she's pregnant, she has a postnatal period, and then she has a subsequent pregnancy. And even a pregnancy, a normal pregnancy, can put you at higher risk of developing cardiovascular disease down the road. But it's well down when women are in the postmenopausal stage, typically. Well, how about if they have preeclamptic pregnancies? That gets all shifted up. That you, even though you haven't had clinical detection of cardiovascular disease, no doctor has told you you've had, your blood pressure's been high. Now that I've seen you a couple of times, and we really got to look deeper into this and think about whether or not you're developing hypertension. They fly under the radar, but those women are going to become, if you have a hypertensive disorder of pregnancy, particularly something like preeclampsia, they're going to really, it's going to accelerate their timeline to when they're going to develop that disease. We've known this kind of thing for a long time. No one really understands what's going on. We also know that people had always thought about reproductive health in one silo. We have a group of investigators, clinicians, etc., taking care of women during those for reproductive outcomes. They used to call it bikini medicine. We think about breast disease in women. We think about reproductive health outcomes during a pregnancy, and really focused a lot on that. Cardiovascular health was handled by the internists, the cardiovascular physicians, etc. And we weren't sort of putting those two things together. But we know now that reproductive health is linked to the long-term health in the woman. Here we're talking specifically about the lifespan risk of certain diseases in women are highly linked to some of the complications of pregnancy. If we're just going to think about that, gestational diabetes, low birth weight, having a preterm delivery, preeclampsia, as we mentioned in the last slides. All of those things have been linked to a doubling, at least, of her risk for developing serious cardiovascular disease in both the premenopausal, but particularly the postmenopausal state as well. And we can talk about it, but we also know from our work in environmental health, and there are large bodies of evidence, some of which have come from our group as well, that environmental exposures, like PFAS exposures, are linked to things like increased risk of gestational diabetes, increased stress exposure in women. It can be linked to many of these reproductive complications that are on the left-hand side of this slide. So we know that environment's playing a role there in what mom's exposed to during her pregnancy, but it also is sort of her cumulative lifetime risk that she carries into that pregnancy that we have to do better and start to understand a little bit better. So we really want to think about pregnancy as a critical window of development for a risk for mom's health long term. So we're focusing more on our mothers, not only because of what health effects the environmental factors may have on programming the child's health, but how about how it changes her trajectory after that pregnancy, how multiple pregnancies change that trajectory for multiple chronic disease risks, the major morbidity and mortality inducing outcomes for women, chronic respiratory disease. More women are likely to develop asthma after complicated pregnancies, and likely due to the environmental factors that she's exposed to during that time, really shifting her biological response and physiology that doesn't get reset to where she might have been pre-pregnancy there, and it continues on to contribute to that risk. And it's really all of the environment that you see pictured on the left-hand side that we need to think about, which is more of that exposomics type of framework. And honestly, when we wrote our grant, we decided, well, we really should get a Birch grant. Let's build interdisciplinary research careers in women's health. Let's train the next generation, not only focused on how environmental exposures are critical to early child development, et cetera, not only for what's happening to the child right now, but their long-term risk of outcome, health outcomes, a healthy trajectory, a less healthy trajectory, and how we can get them back on that. But let's also think about the mom as we follow her through these pregnancies and as she ages as well, so we can fill some of these gaps in our understanding. And we know this is some of the things we've started looking at are, well, how do these environmental factors change the different physiologic profiles that we might be interested in during pregnancy that may affect women's health as well as the children. And one of the things we looked at were steroid profiles. So we actually ran a metabolomics panel, not just 5 or 10 different factors, but we looked at hundreds of metabolites. And then you can pull out of that data using machine learning techniques, et cetera, various classes of steroids, which we know are very important to keeping you in a healthy balance. There needs to be some optimal balance of a lot of these different types of steroids. We talked about cortisol as one of the most widely studied for things like stress response, corticosteroids, but also looking at androgen steroids, estrogenic steroids, pregnenolone, progesterone. These are all sort of in that soup, but talking back and forth together, and there's some optimal balance that's good for you, good for me, and then there are all these different environmental factors that are going to push and pull on that and change that. And that is what we need to start to understand as clinicians, to see how we can use those kinds of information to manage a person during this state, not only thinking about the pregnancy and having a healthy pregnancy and outcome, et cetera, and not having a preterm delivery, not developing things like diabetes, et cetera. When can we get to that and kind of fine tune those things? And this just shows you also, we looked at males and females on the top. It looks at it in everybody. Higher stress exposure in the moms was associated in the dark black left of the dotted line. That means you had lower levels of androgenic and estrogenic steroids, but it really was in boys. So it really was, this is going to be most impactful when you're looking at mothers carrying boys. And this slide sort of reiterates some of the same things, so I think we'll just move on to the next thing. So what did we do when we put this proposal together to get funding? And we got close to $1 million a year for this program. So we went for a program that would fund a lot of scholars, as many as we can. We can fund 3 a year. Not a lot, because we get tons of applications for this, because there's a lot of interest in it now. But it helps, and it also funds some of the work we're doing already around exposomics, but to tailor it more directly to specifics that we might want to understand because we know differences between men, women, boys, girls, depending on what life stage that you're looking at. And we're gonna really what we want to do is incorporate in OBGYNs more specifically, or people doing like women's health research, to think about environment, to incorporate some of the tools that we've been using to make advances in children's environmental health, and to do it in women's health. And I got to tell you, when I started going to the literature, I was stunned by how little there is, particularly thinking about things like pregnancy as a critical window for women, and really doing research to understand how environmental factors influence the trajectory for her own health going forward. And that's when we were all in, because there's just huge gaps in literature, and who can do it better than what we've already been doing around children's environmental health. One of the things that is particularly interesting to the program is our Greener platform. And some of you may be familiar with it, and some of you may not. And so I'm just going to spotlight it here too. It's the Greener stands for Geospatial Reproducible Environmental Exposure National Exposome Resource. That's a lot. It's easier to say Greener. But basically what we've done is created this platform where we can link based on your address, where you live, where you go to school, where you work, etc., whichever environment we might be most interested in, given the question that we're asking, we can link that through this process called geocoding, and then link that address, where you live, etc., to various indicators of exposures that are modeled by our experts in air pollution modeling. We look at temperature modeling. And so it's really right down to the residents, and you can see the map of the US. Doesn't matter where you are, we can do it across the whole US. And we can do it across multiple years, as you can see the map here just showing you PM 2.5. We talked about earlier on that we looked at PM 2.5 exposure in utero, predicting heart rate variability in kids, which may be a harbinger of mental disorders, as well as cardiovascular disease and other chronic disorders like that. Well, if someone has a cohort across the U.S. and over a different time or a certain time span, they can give us address. We can link it, and we can link it to more than 100 different exposure data sets right now. Multiple air pollutants, things like green space, walkability, temperature, lots of social determinants of health, safety in the neighborhood, these kinds of things as well. Because we want to accelerate people's ability to do women's health research and bring the environment in right away, is one of the things that we pitched for our training program. But we don't want it just to be at Mount Sinai. We really want to open this up to anyone who's interested in doing that, because we want to advance this kind of science and help women's health improve as fast as we can. The LEAP program, it's co-led by myself and then Dr. Keisha Carroll, who's a professor in the Department of Pediatrics. Many of you may know her. She leads the T32 training program in environmental pediatrics as well, with Dr. Robert Wright here. And she is a co-director of our KL2 program for junior faculty, also funded through the NIH, through the CTSA. And she leads a K24, which is a patient-oriented research award as well, where she is training people. A lot of it is in environmental exposures, exposomics, and child health. But she's always been interested in nutrition in this context, which I think is a very important lever that we need to incorporate into the women's health as well. So this is a nice blend of our expertise to pull this thing together. And just want to introduce you to our first scholars. We're just in year one of that program. Again, 3 scholars, that's great. We have another K award from the NIEHS where we fund 2 or 3 scholars a year. But I can tell you, we get 30 applications for, we just need more and more of this, because we have to train the next generation to really move this stuff forward in a quicker way. Francesca is an assistant professor in the Department of Public Health. She's looking at prenatal maternal PFAS, which are perfluoroalkyl substances, are forever chemicals, some of you may know, exposure in childhood sleep, and looking at sex-specific programming there. Jamil is in the Department of Environmental Medicine. He's looking at sex-specific programming of prenatal metal mixtures on autonomic regulation. We said it's a particularly important early marker of later behavioral and neurobehavioral developmental risk in these kids. And then at Ronki is also in the Department of Environmental Medicine, looking at the modifying role of placental iodine, starting to bring nutrition in as a mitigating factor in the that may protect you from things like oxidative stress and chemicals that might induce that in the placenta and in its relationship to maternal child neuropsychological functioning. Again, looking at those early risks, and always sex specific, because we really want to look at what drives the differences between women's health trajectories and men and boys and men as we go forward as well. We'll also learn much more about health of men and their developmental trajectories if we study both together. And honestly, that's not the way science has happened. It's been, when they looked at cardiovascular disease, if you look at the studies, most of them included men. They didn't want to deal with the complexity of having menarche in women and going through pregnancies and factoring all those things in. Well, you can see, I hope, we need to do that to inform both women's health, but also men's health, particularly related to environment. So I'll stop there. It's a very exciting program. We want more of it. We want more trainees. One of the other things that came out of this program is when I took over as Dean for Public Health and looked at the curricula for training our Masters in Public Health students and clinical research students, etc. We had one course on women's health, one course in the whole curriculum, and it's really, none of it touched on environmental exposures that might be related to it. So that's going to change as well. We will, innovate and modernize those curricula as well. So we can train all students, medical students, our MPH students, etc., as well as our research trainees in a lot of what we're talking about here. So I think I should stop share. And see if there are questions.
Thank you so much, Dr. Wright, for that excellent presentation. And now we'll try to get to some questions, and please make sure to use the Q&A function to submit them. So I'll start out by asking this question, and I know it's a big question. For someone listening today who wants to protect their health or their family's health, what are the most important environmental exposures to be aware of, and are there practical steps they can take?
Yeah, so we know that there's evidence for many environmental factors that are health relevant. What do I mean by that? They've been linked to these different health outcomes. And things like the metal exposures that I talked about, I touched on here. We started out looking at one metal at a time, lead, arsenic effects, and now we know it's the mixtures of those. So, we screen our homes for lead in the water and those kinds of things. Those are protective policies that are put in place to protect us from those kinds of things. If you have concerns over those kinds of things, there are things that, you can reach out to Mount Sinai. And we have, and I think Sarah Evans is on, and she can also join in on the conversation. But there are many links to educational documents, etc., that are helpful to you to think about what do we know, what can you do for X, Y, and Z, whether it's the PFAS, which oftentimes are in lots of things that we use in our homes every day. Cookware. You can actually do things like understand that sometimes those chemicals are in cookware, sometimes they're in food packaging, sometimes they're in the cosmetics we use or the shampoos we use and those kinds of things. If you knowledge is power, so then you can actually start looking and reading labels, and sometimes things aren't on the labels, but some of the documentation that is provided through the Mount Sinai Institute for Exposomics and the PESHU will provide that kind of information for you. Air pollution. We know air pollution is not healthy for us for many health outcomes. So you can look at the air quality index and understand if you go outside, maybe you want to do things to mitigate that risk. Don't spend so much time outside. For example, when the wildfires were burning and we saw such air pollution even in our city here in New York City, um, so you might change your behavior because of that. I want to say I didn't talk a lot today about the mitigating factors, and we also look for resiliency factors as well as the harm-inducing factors. We need to understand both. You can do things, we know how these chemicals get in the body and how they function. To some extent, we need to know more, but we do know you can balance your diet and eat nutritious various nutrients that help mitigate the effects, even when you have to be exposed. We live in the city. I walk
What
to the
are
train
those?
every
What
day.
what are those nutrients?
So
What?
those would be things like antioxidants. So increasing a diet where you're higher in antioxidants that can offset many of the toxins that we're talking about.
Mhm.
There are also certain polyunsaturated fatty acids that are protective to the brain, to other organ systems, the heart, etc. And so you can eat foods that have higher levels of those and reduce your intake of things like fructose and sugars that we know can contribute in an additive way. So now you might be exposed to certain chemicals, the PFAS, etc., but also the sugar intake you're doing, those things can act together, multiply the effects, etc. So
Mhm.
nutrition's a very good one. And I don't want to, sound sort of simplistic on what my mother might have told me, when I was growing up. Exercise, eat lots of fruits and vegetables. Exercise is another one. Getting exercise can actually keep your body in balance with some of these different physiologic factors that we know are important to our health. And even when you are exposed to toxins, it can mitigate it can decrease inflammation, et cetera, et cetera.
Mhm.
And then social relationships. I study that a lot. I didn't talk about it here, but social connectedness, social relationships, the caregiving environment when you're talking about young children and their care providers, we've actually shown that it can mitigate the effects of toxic stress, and it actually can keep your physiology in that more optimal balance that we like to see.
Mhm.
So there are those kinds of things you can do. So you can, like, on the one side, get the knowledge, understand what things you're looking for to be sure you can reduce your exposure as much as possible as you go along. But then you can also do these other things that can actually protect you, even when there are exposures that you may or may not even be aware of. Honestly, but there are some things we can track and be aware of.
Right. Great. Thank you. This is a question from the audience. Can you comment on the impacts of women not being included in research studies as subjects? And has that led to the wrong treatments for women?
Yeah, and just before I do that, Carla had posted in the chat some of the resources that I was talking about from our
Oh,
learn.
okay. I didn't see that.
Yeah,
Thank you.
there's a link there just so folks know. So yeah, this has been one of the problems is that, and even still, I'm currently involved with a working group where we're looking at this again. How are we doing, including women in clinical trials to look at different treatments, and why are they being excluded? And should it be an exclusion criteria? And lots of folks, they just exclude if you're of childbearing age, they would not have women in there because they were concerned about pregnancy and harm to the fetus. Well, there are some things, even if you're pregnant, it's not a necessarily an exclusion criteria because we have data on safety, et cetera, for some of the drugs that might be tested in these clinical trials. Um, it's led to not as effective therapies for women, right? Because sometimes we did this. Yes, there's limited data on women, premenopausal, postmenopausal. They're not even most of the time they hadn't even considered that. So what's the best we can do? And they use drugs that were shown to be effective in the other members of the population, and they may or may not be effective in women.
Mhm.
So that is something that we have our eyes on as a clinical investigator group. NIH, the National Institutes of Health, would fund a lot of this. Industry that funds a lot of this, they do have their eyes on that. And we keep doing these iterative looks at how are we doing so that we can keep pushing and do better. Because I can tell you, we can still do much better there.
Right.
And honestly, it's through the Birch program that has developed a lot of the leaders in women's health research who've really brought those people now to leadership positions. I said it was their 25th anniversary. Many of those folks pushing that, driving that, came out of these kinds of training programs. So another example of why it's so important.
Great.
Um, yeah. And the other
Well,
thing I would say, if we don't understand environment, we may not understand why some drugs work in either men or women, better or not, right? We may be given
right.
treatments that if you live in a certain environment, you have high levels of air pollution, poor diet, high levels of exposure to metal mixtures and PFAS and other chemicals, your biology is different. How you function is different. So now I give you a medicine for even your asthma, and a lot of people, we think we understand why this drug should work in asthma, but it only works on 20%, 30% of people. Why is that? It's because this missing piece. We need to do better, and that's for women and men as well, quite frankly.
Mm. Okay. Another question from the audience. Should primary care or OBGYNs be talking to pregnant patients about their long-term cardiovascular disease risk? I think you mentioned a little bit about that. And how do we get them to make these connections for their long-term health trajectories?
Yeah, the OBGYNs, they do understand that if you have a pregnancy with a complication like you develop hypertension or unfortunately you develop an even more severe hypertensive disorder of pregnancy like preeclampsia, they know you're at greater risk in that next pregnancy, not only of having preeclampsia or hypertensive disorder, but um, the hypertension in and of yourselves. How much they're talking about it, they do talk about that. I'm not sure how well we're doing with connecting them to the cardiologist, for example. Well, maybe that's a woman that needs to be monitored more closely. I know they're thinking about it more. Definitely going on here at Mount Sinai. If you're at greater risk of developing asthma or reduced lung function as you go forward, not just cardiovascular disease. So there's a lot of pulmonary physicians, cardiologists who have become very interested in this. And it really is going to become, I think, subspecializations where they're really focused in on this. Bringing data so that they know what to do is going to be very
Mhm.
important.
Mm. Very. Thank you. Can you talk about other ways to train clinicians treating women? Are there changes to clinical training programs that you could implement? You know, what do
Yeah,
you see? What
so
would you want to see? How would you want to see this working?
well, it needs to get back into the classroom, right? At all stages of when we're training, not just medical students. I'll have to say the medical students get more of this than I ever did when I was in med school now. Can we do better? We still can do better. Absolutely. Sometimes it's because you have the older generation not on their radar. So you got to train
Right.
the current practicing clinicians as well. And we do that through lots of different things, seminars, meetings that they have to go through. Make sure that we're talking about it at the meetings that the clinicians are going to, the grand rounds that we have in our hospitals, in our medical centers, et cetera, and disseminate it. It takes time to do it that
Mm-hmm.
way. So much more quickly can we do it? I think we really got to start thinking as environmental scientists, how do we boil this down to something that we can hand the clinician, a report card or what have you, where they can actually use it when they're doing that visit, and it's going to be an important part of everything they do, just like screening for all the different things they do to maintain optimal health in different stages. We have
And
to
do
do
you,
better. We do need to get to that implementation piece. That's another
right?
thing that we're all thinking about here more seriously. Um, is bringing in implementation science. We need to recruit people who really that's what they're thinking about, right?
Mm-hmm.
We do need to do that. It's a mandate now from the National Institutes of Health that you do translational research, show that there's going to be an impact. Implementation science needs to be a part of what you're doing. And that's great. I think it's great. But if you look at even here at Sinai, we need to bring that expertise in. We're looking for it now. We're going to build our expertise around that. Sometimes the mandate from the people who are giving you the money to do the research is a powerful thing.
Mm-hmm.
So it's happening, which is all good things.
Right. And do you envision the greener platform being used to guide patient care?
I would love to. We're actually. I just had a conversation about this, in the last couple of days with leadership here to think about how can we now. It's ready. We want to disseminate it more broadly. We can map our patients where they're living, and we can actually. We also know what their burden of disease is, where we have pockets of higher levels of X, Y, or Z, diabetes, asthma, cardiovascular disease. Well, why is that? Could it be the missing link? It could be some of this, the environmental factors. How do we incorporate that into then our clinical, thinking, our research that then gets to the clinicians to help with that clinical decision making?
So how do you see this changing in 5 to 10 years? Do you see it changing?
I do see, in 5 years, um, I think we're at a pivotal point in medicine because we now have these tools like machine learning, AI, computer power to merge together all these different data streams, and then the scientific expertise to help make sense of it and get it to how to get it to the clinicians, how to implement it, how to get them to think about it. That's the implementation science piece. I think we're a little further away from that. We need to do better there. I think we're in the next 5 years, though, you're going to be seeing some examples of that.
Mhm.
Some early wins. And we kind of are thinking about where those things might be. We're doing some of that to some extent now. Um, cardio cardiologists are extremely interested because it's easy. There's a lot of data that says, hey, if we have a bad air pollution day, more people come into the emergency room with angina and maybe even a heart attack, right? We know this. We know that kids come in or people come in with asthma more when they have a bad air day. It
Right.
can induce that as well. So we're already thinking about some of this in a smaller way, but how do we really just bring it in more comprehensively is the challenge. In 10 years, I think um, there. I do think you'll really see it being incorporated in 10 years. 5 years, you're going to start seeing it more and more. Maybe it'll be in various in certain subspecialties like cardiovascular medicine. I see it happening already. The pulmonary physicians are interested in it. The OBGYN, because we know it's such an important period for child health, it's gotten a lot of attention already, but we need to do better for the women themselves.
Yes. Well, thank you. That was our last question. And for everyone joining us today, your feedback really matters to us. So please take a moment to fill out the evaluation form. You'll find the link in the chat. And thank you so much, everybody. Thank you, Dr. Wright. and have a great day.
Yeah, thanks everyone. Have a good day.